Welcome to Module 2 of Part 1 of this course on fluids. Congratulations for being here, or should I say thanks to your ancestors who managed to survive long enough to pass their genes down to you despite no effective medical care until the mid-20th century. Doctors don't usually heal patients, they just create an environment in which the body can heal, assuming that it has sufficient physiological reserve to do so. Over hundreds and thousands of years, we evolved systems to keep our bodies alive despite horrific injuries sustained in trauma, conflict, and accident. Most of the time that involves significant blood loss. The body evolved a series of defense mechanisms to keep itself alive by shutting down systems that use up too much energy and by prioritizing blood flow to the heart and brain. It then accumulates a series of tools that we call inflammation to set about healing the injury. This process that ebbs and flows is known as the stress response. It is adaptive, which means that it is normal. The magnitude of the stress response is usually proportional to the degree of injury. Whether you're a doctor or a nurse or any kind of healthcare provider, you will encounter patients who are injured and have undergone a stress response. To follow the remainder of this course, you absolutely must understand this stress response. If you don't understand it, you may deliver inadequate or unnecessary treatment for your patients, or you may fail to recognize essential physical signs.
Tutorial 6, the perioperative stress response. Previously, we looked at fluid and electrolyte distribution in the body, fluid and calorie requirements per day, and isotonic resuscitation versus hypotonic maintenance fluids. We also looked at the risk of chloride overload despite using hypotonic fluids. This time, we will discuss the stress response, perioperative fluid distribution, and perioperative fluid planning. Let's start with a clinical scenario. You are called to the postoperative surgical ward. Mildred, who is 61, underwent a surgical procedure this morning. It's 11 p.m. and you were called because of an elevated early warning score. The early warning score is a system used in many healthcare systems in which nurses record a series of physical observations. When those observations are outside specific limits, they score at a certain number, maybe 1, 2, or 3. When the combined number reaches a certain level, a doctor is called. With increasing magnitude of that score, the response advances to ultimately involve the critical care team. Mildred, when you're called to see her, has a GCS, a Glasgow Coma score of 15. Her temperature is 39 degrees Celsius. This is high. Her blood pressure is 90/50, her heart rate is 100, and her urinary output in the last hour was 15 mils. The intern believes that Mildred is septic, and the intern wants to start broad-spectrum antibiotics. Is this the correct thing to do? To understand injury, illness, or what happens after surgery starts, you really must understand the stress response. If you're a clinician working in perioperative medicine, critical care, or emergency medicine, the stress response rules everything that happens to the patient. It's an adaptive response that happens when there's an injury, and then all sorts of things get activated, and they can be easily just delineated into 3 things. First of all, there's an immune response, there is a simultaneous metabolic response, and then there is activation simultaneously of the neuroendocrine system. And the purpose of this is essentially to keep the patient alive and give the body a chance to heal itself. It is fully adaptive. This is something that evolved as we evolved as a species, and it's supposed to happen. And it balances neuroendocrine activation, blood distribution, inflammatory activity, and alterations in oxygen delivery. The chairman of the board of all of this is cortisol. Cortisol is the key component that holds all of this together. And the major organ that drives the stress response is the adrenal gland, both the cortex and indeed the medulla. The adrenal gland, once you have this injury, will immediately release cortisol, epinephrine, that's adrenaline, norepinephrine, that's noradrenaline. And part of what these chemicals do, and they do all kinds of things, is to act on arterioles and in particular venules and vasoconstrict them. Once they're vasoconstricted, flow, particularly into the splanchnic circulation, slows down, flow into the kidney slows down, the macula densa absorbs this, and there is an increase in the release of renin and then angiotensin. That causes vasoconstriction, and then of course aldosterone is activated, causing salt retention. Once the osmolality of plasma goes up, the brain recognizes this through osmoreceptors, and antidiuretic hormone or vasopressin is released from the pituitary gland, and the effect of all of this is to reduce urinary flow and to retain water and salt. Now let's visit the microcirculation for the first time. We're going to spend a lot of time later in this course looking at the microcirculation. This is a very simple approach to it. And this is a picture of the microcirculation. You can see on the left you have your arteriole taking blood from the heart. Then there's a big capillary network, and on the far side there are venules that are capacitance vessels. And on the outside you have your lymphatics, which hoover up essentially all of the liquid from the interstitial space. Flow into the microcirculation is controlled by pre-capillary sphincters on the arteriole side and then post-capillary sphincters on their venular side. Normally, fluid flows through the microcirculation and a small amount of fluid extravasates into the interstitium.
That small amount of extravasated fluid is mopped up by the lymphatics. Most of the fluid that goes into the microcirculation travels into the venules.
In states of hypovolemia, stress or shock, the effect of all of these vasopressor drugs, epinephrine and norepinephrine in particular, is to tighten up the pre and post capillary sphincters, and then of course the microcirculation shuts down. The velocity of flow through the microcirculation increases, and this causes a process known as transcapillary refill to occur. Essentially, there is a suctioning effect on fluid in the interstitium to be pulled back into the bloodstream, and fluid is actually reabsorbed on the venous side of the circulation. That is something that doesn't normally happen. So this is the patient essentially auto-resuscitating themselves. The big effect of all of these pressor agents is to remove blood flow from the extremities and from the splanchnic circulation, about which I will speak endlessly later on in this course, and centralize it to the most important parts of the body, those organs that you need to keep you alive, and they are the heart and the brain. So there is preferential perfusion to the heart and the brain during the initial phase of the stress response, and reduced flow to the extremities and the splanchnic circulation. As a consequence, when the stress response is activated, there is hypothermia, tachycardia. The blood pressure will stay more or less the same because of intense vasoconstriction, even if the patient has lost a lot of blood, and the urinary flow is low. Let's put this onto a graph. On this graph, on the y-axis, you can see energy expenditure. Above the line, there is positivity, and below the line, there is negativity. In other words, energy expenditure can either go up or it can go down. We've drawn in 3 different phases into the stress response. There's an injury phase here, and immediately after the injury phase happens, everything slows down. The body essentially goes into hibernation state. The temperature falls. The patient exhibits lots of adrenergic activity. That means organ systems respond to epinephrine, adrenaline, so they become diaphoretic. They're cold and clammy in their extremities, but their eyes dilate, they become sweaty, and the urinary output falls. And this is known as the Ebb phase of the stress response. It's the classic hyperadrenergic shock picture that you may have been thought about, that you see, for example, in someone who's been in a car crash, who's been stabbed, who has a myocardial infarct. But in fact, in pretty much all situations of acute injury, you have an ebb phase. This is completely normal, and it's how the body keeps itself alive once the body has been injured. Here's a picture of our intravascular space, our interstitial space, and our intracellular space. And what happens during this ebb phase, you start having this transcellular movement of water from the intracellular space into the extracellular space. Simultaneously, there is vasoconstriction and transcapillary refill of fluid into the bloodstream. So fluid moves from inside the cells into the interstitial space and then into the bloodstream. The purpose of this is to auto-resuscitate the body with some stored fluid. We're not camels, we don't store that much fluid, but we have a little bit in reserve in our interstitium and in our intracellular space. Now, what happens normally is that this goes on for a while and it gradually just wears off and eventually the stress response moves on. However, with modern medicine, doctors come along or paramedics come along and they'll insert an IV line and start administering intravenous fluid. That immediately reverses the stress response into the secondary phase that is well known as the flow phase or the hyperinflammatory phase or the hot phase. And so what happens then is the patient vasodilates and then they start to extravasate fluid from the bloodstream back into the interstitium. So you start getting some interstitial edema. The intracellular space, of course, because of osmotic shifts, will start to resuscitate itself. So fluid will go back into the cells, but it starts to collect outside of cells because the capillaries become somewhat leaky. So this is the second phase of the stress response. Left alone, it happens after several hours, maybe a day or so, but it can be advanced by starting to resuscitate a patient. But certainly it happens normally not less than 6 hours after the injury, but of course it can happen at the site of an injury if someone inserts an IV and starts giving fluid. The flow phase is all about an increase in energy expenditure. Now we can put other things over here on this y-axis. It can be temperature. Temperature goes up. We can look at inflammatory mediators or markers like IL-6, procalcitonin, white cell count. They all go up during the flow phase. Glucose, because of gluconeogenesis and glycogenolysis, that goes up so the patient has hyperglycemia. And then what you see physiologically is this hyperdynamic state where the heart rate goes up, the blood pressure drops because of vasodilatation, the urinary output stays low, body weight gains because you're holding on to fluid and often the patient is getting fluid intravenously or even drinking a lot of fluid, but they don't push a lot of that fluid out. And so the fluid balance becomes positive. The flow phase, again, fully adaptive, fully normal, supposed to happen, is the classic inflammatory picture of the host response. You're supposed to get it. The bigger the degree of injury, the bigger the flow phase, the more inflammatory activity that seems to be going on. This is not sepsis. This is not systemic inflammatory response syndrome. This is a normal host response to an injury. Following this, after perhaps 48, more likely 72 hours, everything just settles down and normalizes, and the patient goes into the recovery phase. If you were to look at the typical fluid balance in a patient who goes through the stress response, it looks a bit like this. And again, the y-axis here has the fluid balance, positive and negative. Above the line is positive. We have our injury here at the very beginning. During the ebb phase, patients tend to lose fluid for all kinds of reasons. They bleed, they sweat, all kinds of reasons. So they become slightly fluid depleted. Subsequently, once resuscitation starts, they generate a positive fluid balance. After approximately 48 hours, the patients stop retaining fluid and they start to release fluid and everything goes into a state of equilibrium. After 72 hours, the patient starts diuresing off all that resuscitation fluid. And that can go on for up to an entire week, and eventually the body weight of that person stabilizes back to where it started. If you were to look at the patient's weight in kilograms, the patient will initially lose weight, then they will gain weight over the first 6, 8, 12, 24, 48 hours, and then gradually the weight will go back to normal over the course of a full week. In terms of fluid strategy, rarely do we get to see patients in that initial ebb phase, but we may do so assuming that we're in a position to control the source of the injury. But in general, during that first 6 to 12-hour window, patients need to be resuscitated. Up to about 12 hours, they need a lot of fluid just to fill up that potential space that has been vacated by plasma that is extravasated. And often they need a few liters, not 10, 12, 15 liters, but a few liters of fluid. And they will continue to sequester fluid in the extravascular space for up to 48 hours. At 48 hours, and certainly after the first 24 hours, you don't need to be giving big amounts of volume to these patients. After 48 hours, really giving any further resuscitation fluid is completely unnecessary. Everything should be limited at that stage. And beyond that point, beyond 48 hours, and certainly at 72 hours, there should be encouragement for removing the fluid from the body, assuming that the stress response has settled down, that there is not a secondary complication. So patients at that stage should not be given intravenous fluids. They should go into this diuresis or deresuscitation phase. And often during this phase, because they are mobilizing a lot of the resuscitation fluid that is being given to them, they will need a lot of replacement electrolytes, particularly those intracellular electrolytes that have not been administered during resuscitation. Remember, the resuscitation fluids don't contain phosphate, potassium to any great degree, magnesium, calcium. So often the patients need a lot of repletion of potassium, magnesium, calcium, and phosphate. What about Mildred? Well, Mildred doesn't have sepsis. The intern doesn't have to do anything about Mildred's temperature because Mildred is having a normal perioperative stress response. She is not going to have sepsis at this stage because it takes a long time for infections to seat and then to generate enough endotoxin or exotoxin to even activate a stress response. It's very unlikely that this is sepsis, but it should be considered. She could have had aspiration pneumonitis in the operating room. Her major complication in that first 12 hours after surgery is bleeding. So initial complications of surgery are surgical complication. That surgical complication, the first 12 hours is bleeding. Later on, the major surgical complication, of course, is anastomotic dehiscence. The major complications in that first window are anesthesia complications. And then you start having later medical complications like pulmonary emboli, myocardial infarction, infections, etc. So how should Mildred's perioperative fluids be managed? I'm now going to give you the conventional approach to perioperative fluid management. There are lots of fluid losses perioperatively. First of all, if patients are fasted for fluid, they are dehydrated. Often they also get a bowel prep, which clears the patient out. They have quite a lot of fluid losses before they even get to the operating room. Then, of course, there are evaporative losses in the operating room. There is blood loss, some urinary loss in the operating room, and then there's this concept of third space loss. And then, of course, there's postoperative fluid redistribution. Now, if you look at the fluid losses, clearly preoperatively, the fasting losses, well, that's water. Bowel prep is extracellular fluid. Evaporative losses, that's water. And then blood loss, well, that's extracellular fluid or blood. Urinary loss is water. Third space loss is extracellular fluid. And postoperative fluid redistribution is also extracellular fluid. Remember this, that our patients have this big neuroendocrine thing going on here. So they're actively holding on to salt and water very, very aggressively. The patient is very, very primed holding on to salt and water. If you start giving a lot of hypotonic fluid, for example, half dextrose saline or 1/5 saline with dextrose in it, it's isotonic when it goes in, but as soon as that fluid hits the bloodstream, the dextrose is metabolized away, and what you have is a bolus of water with a small amount of salt in it, and we call that hypotonic fluid. And if you start giving boluses of hypotonic fluid to a patient like this, they can run into trouble because of the priming of the stress response. The plasma sodium falls, the plasma osmolality falls, and the plasma to brain osmotic gradient drops. Water moves from the plasma into the brain can swell, and the patient can develop cerebral edema. The result of this is nausea, confusion, potentially seizures, and brainstem herniation. So during that hyperacute phase of the stress response, if you are giving boluses of fluid because the patient is hypovolemic or bleeding, they need those isotonic resuscitation fluids that we talked about in previous talks. And these are the fluids that include plasmolite, isotonic saline solution, and sodium lactate solutions such as lactated Ringer's or Hartmann's solution. Remember this though, that's after the stress response has started. Before the stress response started, the patient is just dehydrated. So ideally, that water deficit will be avoided by letting the patient drink water up until 2 hours pre-op. And sometimes adding some sugar or carbohydrate into that water will help the patient avoid developing ketosis. Let's look at fluid requirements in fasting. This is a cookbook approach I'm giving you. I am not saying that this is what I use, but this is what's in all of the textbooks. The standard way fluid requirements are calculated are 4 mils per kilo for the first 10 kilograms, 2 mils per kilo, this is per hour, for the next 10 kilograms, and 1 mil per kilo for the remainder. You could also use 1.5 mils per kilo per hour. An 80 kilogram person would receive about 120 mils of fluid per hour. Again, if this is maintenance fluid, it should be hypotonic. If it's resuscitation fluid, it should be isotonic. But of course, the patient has been fasting, and there's all kinds of ways of calculating that out. The classic way is to multiply the number of hours fasting by the normal requirements per hour. You give half of the deficit in the first hour. You might add a litre or two for a bowel prep, and then you give 25% of the deficit for the next 2 hours, in addition to normal or ongoing hourly need or replacement of losses. Remembering that those fasting losses are principally water, they're not salt solutions, and that's why it becomes a little bit problematic that you're replacing water loss with really dense salt solutions. In terms of the kind of fluids you give, just to remind everybody, if you give a 5% dextrose solution, that dextrose finds its way all the way across body water, and it will distribute 66% intracellularly and about 33% extracellularly, and only a third of that will stay in the bloodstream. The isotonic fluids, or the balanced salt solutions, lactated ringers or Hartmann's, because they're slightly hypotonic, they distribute to the extracellular space, but also a little bit into the intracellular space. There is an argument for this, of course, because they are giving the patient back a little bit of that water that they have been depleted in, and also they address the issue that probably you do lose more water than extracellular fluid during surgery due to evaporative losses, and they do seem to be a semi-elegant solution to that. Normasol or Plasmolite 148, these are fully isotonic with plasma, and they will stay in the extracellular space and distribute approximately 30% intravascular and 66% extravascular. Isotonic saline have a slightly lower distribution because it's slightly hypertonic, so slightly more of it stays in the plasma. And then, of course, red cell concentrate 100% stays in the plasma. There's a lot of arguments about what happens with albumin, and I will cover that later on in the course. In general, though, these are the fluids that we're going to be using here for resuscitating the patient, these isotonic resuscitation fluids, saline. We don't tend to use that in perioperative medicine because of the large chloride load that we will discuss later on in the course. And so we tend to use either a modern balanced salt solution like Plasmolite or Normasol, or more conventionally lactated ringers or Hartmann solution. There really honestly is no data to support the use of one balanced salt solution over another. Traditionally, some form of sodium lactate solution has been given by anesthesiologists and surgeons. The theoretical benefit of these newer fluids like Plasmolite or Normasol is that they are fully isotonic, so you can use them in your surgery, although I have gone through the osmotic coefficient and shown you that they're not quite as isotonic as people think they are. Certainly they have lower chloride, and there is some accumulating data that chloride might be associated with worse outcomes, certainly may be associated with worse renal outcomes, and there's no calcium, so that if the patient starts bleeding, you only have one IV, the clear liquid in the giving set is not going to clot the blood by binding up with the sodium citrate solution. The big disadvantage of any of these fluids, of course, is the potential for sodium overload. In the operating room, of course, the patient will have other requirements, and there are lots of different formulas for this. One of the formulas that is commonly used is that you look at the amount of surgical trauma and you calculate out how much they need based on that. So if the patient has minimal trauma, you give 2 to 4 mils per kilo per hour. Moderate trauma is 4 to 6 mils per kilo per hour, and extensive trauma up to 12 mils per kilo per hour of resuscitation fluid. Now that might seem kind of reasonable, but when you start adding all of this together, you have a 2.5 litre fasting deficit, 2 litres for bowel prep, 125 mils per hour for maintenance, 12 mils per kilo per hour, which is approximately a litre for a big operation. And the patient just in a 3-hour operation could get 6 litres of fluid, which is more than a third of the volume of their extracellular space. So you have to be a little bit careful about how much you give.
What about post-op fluids? Theoretically, an 80 kilogram patient like Mildred requires 120 mils per hour of maintenance fluid, but I would urge caution in this setting. It's likely that she would have received a generous amount of fluid in the operating room and is likely a little bit over-resuscitated. The fluid balance will be positive. Frequently, junior doctors are called to the bedside post-op because the urinary output is apparently low and the nursing staff are concerned. Low urinary output is normal in this setting due to the stress response, and performing a drive-by saline assault to squeeze out some urine for peace and quiet is poor clinical practice. Urinary output is low in the perioperative period due to the high level of circulating antidiuretic hormone arginine vasopressin that gradually wears away over the first 48 hours. Also, fluid boluses given during this period contribute to overall positive fluid balance, but it gets worse because that fluid contains a large amount of solute and it's really difficult to get that stuff out of the body. So my suggestion is, if you are going to administer fluid post-op, please avoid persistent and nonsensical infusions of resuscitation fluids. That inevitably leads to a hypertonic state, and it is so difficult to de-resuscitate electrolytes out of patients who often become hypernatremic, hyperchloremic, and hypokalemic post-op. It is my practice most of the time to give no maintenance fluids post-op. If you have to do so, limit maintenance fluids to 2/3 of requirements and bolus fluid only for blood loss and hypotension, never for low urinary output, and commence oral intake of water as soon as possible.
Let's review this tutorial. In this tutorial, we discussed the ebb and flow phase of the stress response. We looked at how the body retains fluid in stressed states. We looked at how resuscitation fluid redistributes when given intravenously, and we looked at how to estimate using the classical approach, perioperative fluid requirements. The next time I will discuss the concept of third space fluid loss, what it is and what it is not, the stress response of critical illness, capillary leak syndrome, and then of course the use of resuscitation fluids in critical illness.
That was the stress response, an absolutely core component of understanding normal adaptive physiology, where the patient will undergo a series of neurohormonal, metabolic, and inflammatory changes that manifests as acute inflammation. It is normal and predictable, and we see it all the time in patients undergoing routine surgery or who arrive injured to the emergency room.